Okay. So kind of getting into pharmacology and how do they work, um, you know, that's how we break it down is you first have to think about, safe drug use, because every drug has the ability to not be used safely. So what do we do? Understanding how they need to be administered. Because one thing that's really important, and this is just a practical concept, is most of the time when the doctor prescribes medications, the technician is usually who goes over the medications when the owner picks up. I mean, I've always done that every job I've had. And so there's certain things about medications that are crucial to timing, route, the proper interval, the proper storage. Sometimes you tell owners give a med once a day and they're like, well, I'm going to cut it in half and give once in the morning and once at night. But the way drugs are dosed, the client doesn't have that flexibility. If we say it's to give once a day, it's because we want it once a day. And also checking with your client to make sure that they're willing or able to give a medication, because sometimes people cannot medicate their cats and they may have to come in for injections versus sending home. So those are just some like practical concepts about pharmacology. We're making sure everything is made up properly, proper, dilutions, using cleanliness, good lighting, and it also, a lot of times people come into you, and talk to you while you're filling medications. You don't want to get distracted. You want to make sure you're doing everything. And then also thinking about a drug order, knowing all the components of a drug order. Number one, what drug, milligrams, what route, oops, okay, well, my computer, part of the drug route, the interval, and then also how many days, is this, how many days of medication we're going to need. This is kind of a concept, and about the textbook says there's the 5 rights of drug administration. And I think this has kind of been burned into your brain, but your right drug, your right dose, your right time, right route, make sure you have the right patient, but also right documentation. Everything needs to be in the record. So usually if it's metronidazole, 250 milligrams, 1 tab BID times 7 days. So the owner is going to give 1 tablet every 12 hours for 7 days. So, and we know that's for what patient. We're giving it orally. We know the interval, and that's kind of the components, and then making sure that that's documented. Sometimes people write metronidazole 2 a day. What milligram? How many days? That all has to be part of the record. And the whole reason, the nuts and bolts of why it's important to know the interval, the amount, is we want to get into therapeutic range. And that's why there's not really flexibility if the doctor says twice a day versus once a day versus 4 times a day. It's keeping the drug, getting it into the therapeutic range and maintaining therapeutic range. So, if doses are skipped, days are skipped, or if a person decides to take that Duramax that's supposed to be once a day and break it in half and give it twice a day, are we going to get to the proper therapeutic range? You have to get it to a certain level. But knowing this definition, is the therapeutic range is the drug concentration that produces the desired effect.
Hey, Landa.
Yeah?
Sorry to interrupt. Brittany Thomas is in here also.
Hello. Okay, Brittany.
Oh.
Thank you. Okay, so if we think about the therapeutic range, it's the onset of action, the peak action, and the duration of action. So when we give a dose, okay, how long does it take to cause an effect, and what time is our peak, action? Now we have to be careful. We don't want to get, toxic effects. So that's why we stay in the proper dose. So we don't, again, more of something isn't always better. Again, you don't want to get into that sub therapeutic range either. And then when the drug is going to wear off, this is typically when we're going to potentially give our next dose. And this is all determined, by the drug. All this information is in Plum for every drug that we use. So, and again, this is the doctor's job to prescribe this, and the doctor is going to choose the interval, but it's upon us to impress upon the client, why is that interval important, and why? Because clients will always lovely do their own thing. So it talks about what's onset of action. Once it, and onset of action, this drug has to make it to the plasma to get into the bloodstream to get to the target area. So, if you guys remember, route is going to be different for certain drugs. And there's extra notes under here, but let me, so if we want to keep a drug into therapeutic range, because if it's supposed to be for 7 days, our goal is to keep that drug in the animal at a therapeutic range to take care of, why they're getting the medication. First of all, the drug has to get absorbed. Once the drug is given and it's absorbed, it has to be distributed to the target tissue. And then the drug is also going to get metabolized, and then it's going to get excreted. So if, how fast that happens, and I was just doing injectable agents with my other class. I don't know why this keeps flipping. But if you remember, I talked about ketamine in the cat is pretty much 90% actively excreted through the kidney, active drug, and if we have renal disease and we're relying on the kidney to excrete this drug, then we can potentially have a prolonged effect where we're, normally we would get out of the therapeutic range. The cat starts to wake up and starts to recover. But there's all kinds of, you guys have been probably experiencing it now, there's all kinds of differences in when your patients wake up, body temperature, metabolism, age. There's lots of things that affect this, but dosages, intervals are designed to stay in our therapeutic range. And then keeping it safe, is keeping it without getting the side effects. The route is going to be important, the dosage and the interval. Now, for example, I impressed upon you guys, and I'll just use anesthetics as an example, that you have, typically anesthetics will have, acepromazine will have an IM dose and it will have an IV dose. It also has an oral dose because you can give it, via tablet. But what can happen, is, if you give the wrong dose or the wrong dosage via the wrong route, you have to decrease your IV dosing because you're going directly in the bloodstream. So again, some of route and dosage are going to depend on the effect that we want. Now, if the two routes of administration, and this is good for board exam, is enteral and parenteral. Parenteral, para, apart, entero, intestine. This is something that's given outside the intestinal tract. The way I used to tell students, it's like parenteral, I always think of injectable, and a parent needs to give an injection. If that's a way that helps you remember parenteral versus enteral. But typically, that could also be inhaled. That could also be topical. But injectables are mostly your parenteral. And then enteral is if you're giving it through the GI tract. Okay, so some medications are going to go oral, and that's PO, and some are going to go, injectable. Gosh, must be on some auto setting, and I don't know how to change it. So injectable, IM, IV, and sub-Q are the most common routes that we use. IP is intraperitoneal, so sometimes that's used in exotics to give, think drugs can be absorbed in the peritoneum, which is the lining of the abdomen. Intradermal, sometimes we give things in the skin layer, like you're doing skin testing. Intra Now, IA is articular. If you're thinking arterial, there's not really, we don't like to give drugs in the arterial system. So IA is articular. So because you can put drugs, anti-inflammatories, lidocaine, morphine, things like that in a joint to treat pain, to numb the area. You can do intraparietal or epidural, intrathecal, which are all along in the spinal cord, depending on where you are. And so articular is in here, sorry. Well, IA is arterial, but again, that's not a really common route. So articular, intramammary, intraosseous. Now, intracardiac, as again, you know, sometimes there's intracardiac euthanasia, but other than that, I've never been like, let's give this drug intracardiac. You know, sometimes during CPR, if you can't hit a vein, sometimes people have done, doctors have done that, but you know, again, you know, your most common. Now, IM is, you know, it's associated with a relatively rapid onset and longer duration than IV. Now, it depends on the drug formulation. Now, again, drugs that are water soluble are typically given in the muscle because, you know, so you have to realize that when you're giving the drug. Drugs can be given in like something that's called an aqueous or a suspension. But typically a solution, it's a clear liquid, it has one or more solvents or solutes. Most of the time when you're going in the muscle, your drugs are going to be clear. And again, they can sometimes have to be shaken up, and they can be sometimes like a little bit cloudy depending on drugs that we give, but normally it's going to be clear drugs. And then you have suspensions or liquid preparations that contain particles suspended in a medium. Like Albon that you give for coccidia is a suspension. So when you, again, you always have to tell the owner to shake well, because those drug particles will settle, you know, at the bottom of the bottle. So you always want to shake it up so you get those drug molecules suspended. Now, IM, if you typically, when you give this, some of your drugs are predictable. I think when I think of anesthetics, you know, if you give it in the muscle and a sedative in like 10 to 20, but I've seen IM injections like Kitty Magic. I've seen cats, you give it in the muscle and sometimes it takes them 20 or 30 minutes to go to sleep. And some animals, those days I was helping, were out in like 5 minutes. So sometimes IM is unpredictable, depending on how good of a stick. And sometimes you get it, you know, in a certain area, it may take longer. So I would say not every animal that gets an IM sedative, you know, I generally like to give them 20 to 30 minutes, unless, like I said, they're completely flat out, then maybe you can get them out. But it takes a certain amount of time. Sub-Q, you have to be careful what you can give sub-Q. Now, sub-Q, for example, I told you for sedative reasons, this can take up to 45 minutes. It's not a preferred route because, like I said, it can take so long for the drugs to kick in. You also have to be careful for irritating solutions, drugs that are hyperosmotic. For example, sometimes sub-Q fluids, you can give sub-Q fluids, but you cannot give dextrose sub-Q fluids. That will cause sloughing of the skin. So sometimes people will spike a bag with dextrose. Sometimes people grab, you know, you don't want to grab that bag accidentally. You have to be careful. You know, how much you give sub-Q, like if I'm talking about drugs, you know, we can give a fair amount in one spot. But like when we give sub-Q fluids, I'm giving my cat sub-Q fluids, and, you know, I can put usually 100 mils in one spot. Sometimes we've given sub-Q fluids to dogs, and I've done, you know, 200 to 300 mils in one spot in a bigger dog. So the size, how much you can give sub-Q will vary depending on that. So when we talk about local administration, it's, you know, those, if you want them to work in a certain area, in that specific area. Now, inhalation, like inhalation anesthetics, you know, you're applying them via a mask and they're being inhaled through the nose. Topical medications are usually put on the eye to work on the eye. Sometimes fentanyl patches are transdermal. Now that's going to go through the skin and that's going to get absorbed into the systemic. You know, when you give a fentanyl patch, it's making me mad. When you give a fentanyl patch, you're not just treating pain in the spot of the patch. Again, the drug is being absorbed systemically. Or for example, my cat right now is on transdermal mirtazapine. Mirtazapine is an appetite stimulant. I didn't even know they have a new kind, and you just put the transdermal, it's a transdermal cream, and I rub it in his ear pinna, and he absorbs the drug that way. Thyroid, when my cat was hyperthyroid, my old cat, you put the transdermal thyroid medication, so I didn't have to pill. So some medications that are transdermal, even though you're applying it locally, the effect is systemic. Unless you're putting like ointment, like antibiotic ointment on a wound, then you're putting it on that area on that wound. And then also we can do some medications rectally, vaginally. I'll say something about rectal. We have, and I haven't had to do this, but if you have a seizing patient and if they're in active seizures and snapping and you can't get a vein to give diazepam, you can put like a feeding tube urinary catheter in the rectum and you can give diazepam rectally and it is absorbed. So we also, there's the pill for fleas, and I'm blanking on the name. We can give it rectally if they can't, you know, if they were anesthetized, we could give it that way and it'll get absorbed. Now, when we talk about enteral, which is obviously going through an animal's GI tract, you know, first of all, handling don't have to be as sterile because you're going through the GI tract. Less of a chance of adverse reactions unless you completely, like, you could double the dose and give the wrong amount. But what happens to a drug before entering the bloodstream? Well, if we go underneath here, right here, before entering bloodstream, must be released from the, you know, dissolve and transported through the GI tract and pass through the liver. This is important. If you guys remember from anatomy, when I talked about the digestive system, when drugs, nothing about a drug, if it goes into the stomach, the pill starts to dissolve in the stomach, you know, in the acid, and then it's part of that chyme, or it moves into the intestine. Anything from the intestine, when an animal eats something, gets absorbed into the intestinal bloodstream. All intestinal blood goes via the portal vein to the liver before it enters systemic circulation. So that's what's called the first pass effect. So if you remember, is that technically what you give orally, you're going to lose some of that drug through this first pass effect, through, you know, absorption and whatnot. That's why when we give something intravenous, it has a more potent effect, kicks in very quickly because you're going right to the bloodstream. When you give something orally, it's got to go through the stomach, into the intestines, get absorbed into the intestinal blood, go to the liver, get processed, and then the liver is going to take and release that blood after it's been filtered. Remember, it's kind of like the body's Brita filter, HEPA, liver filter. Everything gets filtered, processed, and then that drug is released into the blood. So, you know, the thing with oral drugs is they have a slower onset because it has to go through all these steps, but it does have a longer duration, okay? You know, because again, once you give something directly in the blood, it's going to be metabolized fairly quickly. Some of the oral, you know, tablets, capsules, boluses, which are those large, kind of like huge tablets that we use in cattle and things. It can be a powder, solution, suspension, or an emulsion. So there's lots of different medications that can be given enterally. Now, a drug dose, what that means is it affects the abilities to maintain the drug in the therapeutic range. You have to get a certain amount of drug into the body to achieve that therapeutic range. And to formulate what dose do we give a patient is how much are we giving to achieve the desired effect. So how many milligrams, how many grams, how many tablespoons, mils, cc's. You know, for every anesthetic drug that you guys calculate, you calculate how many milligrams how many milligrams of propofol did the patient get, how many mils did they get, you know. Now, usually you want to record, when you record a dose, for example, if I want to write in a record that I gave AJ, if AJ was at school, I wouldn't say 1 tablet of metronidazole, Metro 1 tab. But there's different strengths of, you know, that drug. I would say AJ 250 milligrams PO. So I know that AJ this morning received 250 milligrams. That's more accurate because, again, you can have different formulations of one drug. You know, metronidazole at BCA, we've got liquid, we got 250 milligrams, we have 500 milligrams. Okay, so how many milligrams is always going to be most accurate when you record it in the record. And again, that has to be part of the record. Now, most of the time, you know, sometimes this is done. We'll do what's called a loading dose. So the first dose that we give is to get the therapeutic range up very quickly. And then there's something called a maintenance dose. And that's going to be typically a little bit lower dose. And that's when we want to just maintain the drug in the system. A common application for this is if an animal comes into our ER with trauma, and this dog is extremely painful, it has no pain meds in its system, we'll give a loading dose of hydromorphone. That's to rapidly get hydromorphone into therapeutic range. Now, once the drug is in therapeutic range and we achieve a level of analgesia, the subsequent dosing is typically going to be lower because we've got some drug on board. We just now want to maintain it. So very rare, and you don't always do this with every drug. You know, sometimes you're just going to give a dose and then you just give it at an interval. But sometimes you'll do a loading dose to give a boost. I've seen it done sometimes with antibiotics, a lot with pain medications. Now, if you remember, the total daily dose is how much drug did the animal get in a 24-hour period. Let's say, you know, Bo was on 50 milligrams of, you would never give 50 milligrams of pred, but let's just say 50 milligrams of pred TID. So he got 50 milligrams at 8 a.m. and then, you know, the middle of the day and the evening. So he got 50 milligrams 3 times. That means his daily dose was 150 milligrams, but we divided that every 8 hours. Okay, so you're going to have a dose and then a daily dose. And that's, you know, and again, if you're giving something once a day, if you're giving 50 milligrams once a day, then 50 milligrams is your daily dose because you only gave it once. But if you give it twice, it's 100 milligrams. So it's really your dose at one time times your interval. Now, if we're talking about a drug dosage, now a dose is what you decide you're going to give. The dosage is how much drug you're going to give per body weight. Typically, that's like mgs per kg, or sometimes it's grams per pound or mgs per pound, or kilograms. But when you do the dosage, that's what gives you the dose. Now, the dosage interval is how frequently is the dosage given. So if you have the dosage regimen, what that means is that's the dosage, how often you're giving it, and the route. So example, right here at the bottom, if the doctor says, I want 20 mg per kg of cephalexin TID 3 times a day by mouth times 10 days. So that means I would have to do 20 mg per kg, and that's one dose. But now we're going to give that 3 times, and then 3 times 10 days would say how much I would send home for that medication. So for example, now propofol, I like to use that as an example. Propofol has a dosage range. So when you deal with anesthetics, well, every drug we give, metronidazole has a range. You can give anywhere from 5, maybe to 10 to 15 mg per kg. And sometimes, like for metronidazole, sometimes it depends on what you're treating. But say for propofol, I said 4 mg per kg is your really heavily sedated or maybe debilitated patients. 6 mg per kg is kind of like your average patient, maybe a light pre-med. And then if you get up to 8 mg per kg, that's usually if they've had no effect of their pre-med or if they were really, really light, okay? So how you pick the dosage, how I told you in anesthesia, is like, what are you doing? What pre-meds are you using? How old is the patient? Do they have any concurrent disease? Are they handleable? Now, when you have your dose, that's what you finally calculate, and that's what you're giving. So is there any questions about those kind of basics of how we get a dose? And now, if you remember, pharmacokinetics is movement. Kinesis, movement. So pharmacokinetics is what is the movement of drugs once we give them. And you know there's so many factors to this. So what we talk about is how are they moving through the body? What happens to the drug? So there's 4 steps. There's, first of all, the drug has to get absorbed. It has to get distributed to the target tissue. After that, it has to be either biotransformed, which is metabolism, and then it's going to have to get excreted. There is a really good video here, and I could try to link that to your page, but that talks about pharmacokinetics. ADME, A-D-M-E. So if you look at this, when a drug is released from its formulation and enters the bloodstream. So again, if you're giving a capsule, that capsule has to, if you're giving cephalexin, a cephalexin capsule is going to hit the stomach, and then that capsule coating is going to dissolve. And then when it dissolves, that drug is going to dissolve into the GI fluids, and then the active cephalexin is going to get absorbed through the GI blood. It's going to pass through the liver, potentially be altered to some degree, and then active drug will get released into the bloodstream. Now, again, if you give something intravenous, you're going right in the bloodstream. So absorption has a lot to do with route. You know, that's where you can really affect the drug. So the movement, and think about the movement. We're talking about blood, and then that active drug getting into the cell membranes of the target. You know, when I talk about giving propofol, what's the target tissue? The brain. So they go to sleep. If we give metronidazole, the target is, if you're giving it for diarrhea, the target is the intestinal tract. You know, so you think about the drug you're giving, and sometimes systemic, like you're giving the drug and it's going to have its effect at multiple areas. So it really, like I said, what is the drug? Why are we giving it? And then you can kind of figure out what is the target. But you've talked about cell membranes, which a cell membrane is phospholipids, fats. And when we talk about how does a drug get from the blood into a cell membrane, you have these, you know, you've got passive diffusion, meaning it just moves in, doesn't require energy. You have facilitated diffusion, which something has to kind of, I think it's like help it out. Active transport is it's going to need a molecule to actually move it into a cell membrane. Sometimes the cell is going to engulf it, or endocytosis, bring it in the cell itself. And now endocytosis is there's penocytosis and phagocytosis, which this is if you talk about your anatomy, and book has some of this chemistry, whether it eats the cell or brings it in, like attaches and pulls the fluid. There's a couple different ways. The other way drugs, how they facilitate diffusion is, are they charged, or remember, ionized and versus non-ionized. Non-ionized means the drug is neutral, it has no charge, and it's lipophilic. And again, lipophilic, fat-loving, tends to enter the cell because it's of a like, it's of a like substance. Now, the non-ionized drugs have a charge, can either be a positive or negative charge, but they tend to be hydrophilic. And usually if they're hydrophilic, they're going to need to use some type of like active transport facilitated diffusion because they're not of a like, they're not of that fat loving. They're hydrophilic. Think hydro help me. Hydro help. If if it's hydrophilic and it's trying to enter a lipophilic membrane, those aren't like substances. Needs that help. Now, once we talk about a drug being absorbed, it moves from the site of administration into the fluids of the body that will carry it to the site of action. So again, when I give it IV, the blood is taking it to the site of action. That's why intravenous medications usually have a very quick onset because they don't have to go through all these other hoops. You're giving it in the medium, the blood, that's going to take it to the target. But if we're talking about if you're giving it through the GI tract, I've told you everything you have to go through. If you give it through the muscle, there's a lot of blood supply to the muscle, so it's easier for muscular drugs in the muscle to get to, to the area. Oops. Now, again, if you give it something in an IV injection, it's going directly into the blood. It's going to have a direct effect. But it travels, once it's in the blood, it goes to the target tissues. If it's an IV injection, it's going right into the blood. It gets to skip all those different steps. So what affects absorption? Well, the drug itself, if it's lipid, you guys remember when I talked to you about diazepam? Diazepam is in it's not water soluble. So I said, if you give it in the muscle, it's not going to damage the muscle, but the problem is it doesn't travel well. The way the drug is designed, it doesn't travel through the muscle. It's best designed for IV administration. So propofol is the same way. If you give propofol in the muscle, just the way the drug is designed, it's not well absorbed. Therefore, it's gonna be harder for that drug to get to the bloodstream, to get to the target tissue. So the way the drug is designed has a lot to do with its absorption, its molecule size, and we'll talk about patient factors here. So this is a lot to think about. And like I said, I know I'm focusing on anesthetics, but age, I talked about when we give anesthetics to a very young patient and their organs are still developing, primarily the liver, we may use different drugs, or we may, we're worried about metabolism of that agent. If they're geriatric, do they have dysfunction? We may choose to alter our dose. Sometimes fever, vomiting, diarrhea. If they're vomiting and diarrhea, do we have dehydration? If we have fever, that can accelerate sometimes absorption. But that does, usually fever tells us something is going on. But generally, heat increases absorption. Remember I told you guys about fentanyl patches. I said, if you have an animal with a fever and you put a fentanyl patch on that animal, heat accelerates absorption, dilates vessels, absorbs the drug quicker. So we don't We don't want to apply heat to an area with a fentanyl patch, but we don't want also a hot, you know, patient with a fever. If you talk about metabolic rate, if they have a high metabolic rate, it accelerates elimination. Think about hyperthyroid cats. Hyperthyroid cats are typically in a hypermetabolic state. Sometimes they're going to burn through drugs. We kind of say that. You may have to adjust the dose. Now, if we talk about genetic factors, slow metabolism due to a genetically based enzyme deficiency. But remember when I also talked about the collies and the blood-brain barrier and their genetic factor, they're more sensitive to ivermectin. So this isn't a huge one that we deal with a lot, but there are certain medications where if they have a genetic, or we do like rabbits, atrophinesterase, so giving atropine to rabbits, in some it renders it ineffective. So, male versus female and muscle and hormones, is sometimes the hormone, that's why we talk about in anesthetics, we talk about, are they intact? Because, a higher level of fat or a higher level of circulating hormones can affect distribution of the drug. So that can factor in species. There's a note here underneath about drugs staying in the rumen. So say, for example, you give a cow an oral medication, okay? But you know that it has to go to the rumen and contents stay in the rumen for a couple of days, okay? And it's going to be kind of turned around, and then eventually that moves through the GI tract and things can be absorbed. But again, can be a delay in absorption due to their GI movement. So we have to think about that. I also talked about the species differences. Remember we talked about horses and cats and opioids being more sensitive due to maybe their opioid receptor numbers. And so occasionally a species is going to have potentially an effect. Okay. How much drug is in the body is bioavailable. How much drug is available? Think body, life, availability, bioavailability. How much is the drug that actually enters circulation? And again, when you give something IV, and again, we don't really give things arterial, but if you're going into the circulation, it's 100% bioavailable because the blood is what carries the drug to the tissues. And if you put it all in the blood, it's all there. It doesn't have to move through muscle and skin and, the GI tract. It's in the bloodstream. It's available. So, if we talk about a bioavailability number, if something's bioavailable, it has a number of 1. Other drugs can potentially be 100% bioavailable, even if they don't go in the bloodstream. But the higher the bioavailability, the faster the drug is going to cause an effect. Because the faster it's absorbed, then, and I'm sorry these slides look weird. My PowerPoint has been, I don't know what's going on with my PowerPoint. So I'm going to try to look at these gray notes. If you remember, we talked about oral meds and the first pass effect. And actually, the next slide shows it better. If you give an oral medication, it goes into the GI tract. It goes through the mouth. And then it goes down the esophagus into the stomach. And once it hits the stomach, now some drugs are going to start to dissolve immediately when they hit the stomach. But you guys know if you've heard of enteric-coated medications, there's like an enteric-coated bufferin. It's buffered aspirin, but it has an enteric coating. The enteric coating is designed so that it's not going to dissolve. Enteric is pertaining to intestine. So some medications are designed to not dissolve within the stomach, but really to wait till it moves into the intestine. And so once it enters the pH of that environment. Now again, the stomach is a highly acidic environment. And some medications are designed, that's where they want it to dissolve, and some medications are not, they're going to move on. And then motility. If you have an animal that's called hypomodal or low motility, um, that's potentially going to delay absorption because of a slower GI tract. And then if they've got diarrhea, if they're hypermotility, the drug can move through too fast. So that'll affect the drug. And then what is the formulation? Obviously, when you give a liquid, it's already a liquid. Is it a capsule? Is it enteric coated? Is it just a tablet? It's just not coated, So different medications have different coatings for a reason, how they're going to be absorbed. Once the drug, though, once it goes through the intestinal membrane, when the drug is broken down, it'll break down into the molecules that can actually pass through the intestinal lining and enter portal circulation. Portal circulation is the blood from the intestines going to the liver, the portal vein. The portal vein takes blood from the intestines to the liver. So nothing is getting into, the body. It's kind of like a protection because animals are indiscriminate on what they eat. And when things pass through, it's got to kind of go to the liver, and it's a big processing plant. It's like, ooh, you're a nutrient, cool. Ooh, you're a waste, here, go to the bile. Ooh, you got to go to the blood because you got to go here. It's kind of like, I'm going to process everything. Once it goes to the drug or to the liver, it can be altered. Sometimes the liver is going to transform it, and what the liver transforms it becomes the active drug through that biotransformation. But this is the first pass effect. It's got to first pass through the liver, and the liver is going to kind of potentially alter it. But once it goes through the liver, now it enters systemic circulation. And once it's in systemic circulation, it can go to the target tissues. But this is why oral medications aren't like, you don't typically give an oral medication and see an effect in like 5 minutes. It has to go through all these processes before it can become active drug in systemic circulation. So here's some notes under here about the drug. Now, oral versus parenteral. So oral going through the GI tract versus something given outside of the GI tract. The drug form is important. So like I said, if you're giving something solid, like a solid tablet, it's got to dissolve in those gastric intestinal fluids before it can get absorbed. And, sometimes, now I was helping with oral meds today when we were, I was helping with ClinMed 2 or Animal Tech 2 today. And sometimes I said in cats, you hope they swallow it. But a lot of times I will tell owners, here's a little syringe, give them a little water to make sure they do get it swallowed. It doesn't increase the rate of absorption by putting more fluid in the stomach. That's not the goal of doing that. The goal is to help the medication move down the esophagus, make sure it didn't get stuck somewhere, because you don't want an esophageal ulcer. So sometimes I don't do that a lot, but if I'm worried about that, now food can interfere with absorption. So sometimes we will tell owners, now, like when I use a drug, for example, like Rimadyl. Rimadyl is a medication that can cause some stomach upset. So I usually say, this medication is better with a meal. Sometimes Clavamox can cause nausea. I'll say, give it with something. It's kind of like, I can take Advil on an empty stomach. I have no problem. Some people, it'll just like kill your stomach. So sometimes there are certain drugs where we say give with food. Sometimes we want it, on an empty stomach. It kind of depends. There's a drug, very important, sucralfate. Sucralfate is sometimes given for stomach ulcers, but it's given to dissolve and give like a coating to the stomach. But we usually time it, we want to give it on an empty stomach. So a lot of times we tell them give sucralfate, an hour before any other meals or meds. So sometimes there is important timing if an animal sometimes is getting different medications. So that's important um, to know. So should they have food with it? Does stomach acid, increase in stomach acid, alter that? It can interfere with metabolism of the drug, absorption of the drug. So, and obviously liquid medications, you're bypassing that whole dissolving. So a liquid medication is typically going to kick in quicker. But I mean, not everything has a liquid form. So I'm going to stop there. Do you have any questions?